Today we're speaking with Dr. George Sledge, the Balve-Lantero Professor of Oncology at the Indiana University School of Medicine and a physician researcher at the IU Simon Cancer Center. He is the winner of the William L. McGuire Memorial Lectureship. Thank you for joining us, Dr. Sledge.
I'm glad to be here.
Congratulations on the McGuire Lectureship. Would you share the subject of your lecture with us and summarize what you'll be talking about?
Well, Bill McGuire founded the San Antonio Breast Cancer Symposium nearly 30 years ago now. It's always been an exciting meeting, but it's also always carried his imprint and his vision. And his vision, to a significant extent, has to do with how we carry things from the bench to the bedside. Bill was the original translational researcher before it was ever a buzzword. So my talk is labeled, perhaps somewhat foolishly, what would Bill do? Channeling your inner McGuire. And trying to apply some of the lessons that I think he developed to the modern era of genomics. How do we approach this vast and overwhelming amount of data that's flowing our direction in the breast cancer world? How do we apply it to patient care? How do we use the strategies that we've developed in the laboratory based upon this genomics to come up with exciting new therapies for patients with cancer?
You directed the first large nationwide study on the use of Taxol for advanced breast cancer. What is your perspective on the new therapies that are on the horizon?
Well, if you compare that trial, which was conducted in the mid-1990s, to where we're at today, we're in a very different place. The place we're at today has come about as a result of the progressive segmentation of breast cancer. What I always tell my oncology fellows is that if you look at breast cancer, you ought to think of it as a boarding house where a group of criminals hang out. You know, some of them are petty thieves, some of them are murderers. You have to apprehend them differently. You have to punish them differently. And this is breast cancer in 2010. So we're seeing this progressive segmentation based on what we've learned about the biology of breast cancer, which we're now applying to specific and novel therapies for each of these subgroups of breast cancer. It's very different than the first Taxol trial, where we treated everyone, estrogen receptor positive, triple negative, HER2 positive, irrespective of the biological subtype of the tumor.
Would you expound on your work to develop novel biologic therapies for breast cancer?
Well, sure, glad to. I spent a fairly large amount of time, starting in the mid-1990s, looking at questions surrounding anti-angiogenic agents. And we did the first trial with bevacizumab in breast cancer. I've also been involved in a fairly large number of HER2-targeted trials over the years, and had the great pleasure of being at least peripherally involved in the initial HER2 adjuvant trials and in several of the metastatic trials. Today, particularly in the angiogenesis area, what my research and the research of my colleagues at Indiana University is focused on is trying to figure out who benefits. This is always the great question with any new therapy. We start off by giving our therapies to fairly broad populations of patients. We find in doing so that we are exposing some patients to toxicities without benefit. So finding out who the patients are who benefit so that we can avoid exposing folks to unnecessary toxicity, I think, is an important part of the research agenda. It's certainly been part of the agenda of my group at Indiana University.
I know a lot of your time has lately been taken up with your ASCO presidency. Would you discuss some of your priorities in this role?
Well, as president of ASCO, like all large organizations, we have an inordinate number of committees. But if you ask me what I focus my interest as opposed to my time on, the answer is that we're at this fairly crucial point in the history of cancer medicine. We have all this exciting things going on in the laboratory. We are at light speed able to generate huge amounts of data, understand how the cancers work, and we should be at fairly high levels of speed being able to move that into the clinic. We've not been able to do that, and this has frustrated me like it has many of my clinical colleagues for many years. The rapid advances that we've made in the laboratory have actually been balanced by a slowing down of the clinical process as that process has gotten more and more laden down with bureaucracy, as the funding has declined, as the issues have become more and more complex involving things such as patient care issues, financial issues, safety issues, privacy issues, all of which have tended to slow down the overall process of moving things from the laboratory to the clinic. In essence, the revolution is on hold. You know, we live in a revolutionary era, but the revolution is on hold. And I think all of our great societies, societies such as ASCO, such as AACR, and the other societies that care deeply about cancer, should view moving that clinical agenda forward at a more rapid pace an important thing.
Also, you recently testified at the President's Cancer Panel about the future of scientific research. Would you give us your thoughts on the pace of scientific innovation? I know you gave us a hint of it.
Yeah, I think this is an incredibly exciting time. What I'm told is that we are probably no more than 2 or 3 years away from the $1,000 genome. What does this mean? Well, you know, last December 24th, I ended up in the emergency room after cutting a hole in my head and spent $1,000 getting 3 stitches in the emergency room in 1 hour. I think 3 years from now, 5 years from now, when a patient walks in with her entire genome, both her personal germline genome, but also her cancer genome on a memory stick, and hands it to the doctor, that in theory is going to be a powerful and liberating moment in the history of cancer care, when we can know everything about what underlies drug metabolism for the patient, when we can know everything about what underlies what makes the tumor tick, and where every single patient's tumor biology will be informative for the larger biology of the breast cancer problem. That should allow us to move very, very quickly towards not a cure for cancer, but a lot of cures for cancer, a lot of different attacks on the cancer problem. That's an incredibly exciting thing. I wish I were young again.
Dr. Sledge, thank you so much.